So, continuing to my um, videos for the PACEs. So today we're going to talk a bit about the mitral regurgitation. Suppose you see in your cardiology station the patient has mitral regurgitation. So how you will present the case? So first of all, for the presentation, you can give your diagnosis first. Like this patient, I believe has mitral regurgitation. As I was able to appreciate pansystolic murmur in mitral area, which is radiating to axilla. The apex was laterally displaced. Remember that in case of regurgitation, whether it is aortic regurgitation or mitral regurgitation, we expect the apex to be laterally displaced. But don't uh, always examine the patient, don't make any findings. The patient has a regular pulse. This is very important because we know that in mitral regurgitation, the patient or any mitral valve patient can have atrial fibrillation. So must mention that. Then next one must mention about the JVP, whether it is elevated or not, because if this elevated JVP, then it signifies severe mitral regurgitation. There is no evidence of pulmonary hypertension. There is no loud P2. Must mention the negatives, that patient has no evidence of pulmonary hypertension, patient have no evidence of any cardiac failure, no right ventricular heave, and the patient is euvolemic with no evidence of fluid overload. So then if the examiners still don't stop you, just go on and tell the patient that my differential diagnosis in this case will be mitral regurgitation, mitral valve prolapse, tricuspid regurgitation, or VST. Then there are a few questions which are common questions which the examiner may ask you, that how you will know that the mitral regurgitation is severe. So regarding the severity of the mitral regurgitation, remember that severe mitral regurgitation usually have a raised GVP, who may have a loud P2 or S3 gallop rhythm, may have a right ventricular heave, and apex may be thrusting and displaced. So what are the symptoms the patient can have with the mitral regurgitation? So patient may have a dyspnea, they have decrease in their exercise tolerance, and they may have symptoms of fluid overload, usually present with the symptoms of cardiac failure like shortness of breath, peripheral edema, and go on. So what are the tests which you like to do if you got a patient with the mitral regurgitation? So you can say that I like to do the ECG, and ECG will looking off specifically for any left atrial hypertrophy. Maybe we find some P mitral, and then we want to do the urine test to look for any proteinuria or hematuria. If you're thinking about infective endocarditis, full blood count, renal function tests, CRP. The inflammatory markers are needed because if you're thinking about causes of mitral like infective endocarditis, echocardiography needed to confirm your diagnosis, and chest X-ray to do the to see whether patient has cardiomegaly. Examiner may ask you that what is the significance of the JVP? So you can say that it is a visible reflection of pressure in right atrium, and if there is abnormalities in right heart pressure, JVP may be raised, like in pulmonary hypertension. So in case of the mitral regurgitation, recurring about the severity, if there is increased JVP and right ventricular heave, then it means patient has severe MR. So for this patient who got severe mitral regurgitation, we have to refer the patient to the cardiologist, and we want to request for the expedite surgery for the mitral valve replacement, because we know that there is better results before we do the mitral valve regurgitation, before there is any significant pulmonary hypertensions. So what are the indications for mitral valve regurgitations? The examiner may ask you, so if the patient is symptomatic or got pulmonary hypertension or fluid overload. Asymptomatic patients, if there is evidence of declining ejection fraction and increased left ventricular dilatation. And obviously if there is mitral regurgitation following the myocardial infarction. So this is something which is acute conditions. So Regarding the causes of mitral regurgitation, remember that we have degenerative causes, which is age-related mitral regurgitation. There is mitral valve prolapse. So in mitral valve prolapse, we look for any concomitant connective tissue disorders like Ehlers-Danlos syndrome. There can be acquired causes, and acquired causes usually happens quite acutely, and usually because of papillary muscle rupture can happen with myocardial infarction. And the other causes include rheumatic fever and infective endocarditis. These are the infective causes. Coming to the investigations for the mitral regurgitation, remember, would like to do the bedside ECG to look for atrial fibrillation and P mitral. We want to do the urine dipstick for the proteinuria, hematuria for infective endocarditis. We can also do the fundoscopy at bedside to look for Roth spots, and this can present in infective endocarditis. And obviously, we want to check the patient temperature for any infection. Moving on to investigations, let's do the full blood count, anemia to look for anemia, WBC count, CRP-SR, renal profile, and most important is echo, which tells about the extent and severity of regurgitation, any concomitant vegetations or prolapse, gives us idea about left ventricular ejection fraction, and any evidence of pulmonary hypertension. So remember that when you are going to the PACEs, once you give that I want to do the echo, must elaborate that why you want to do the echo, because this one gives an examiner a very good impression. So what are the ECS recommendations regarding the, because we know that we have a replacement, a metallic valve and bioprosthetic valve. So bioprosthetic valve should be considered if the patient is more than 65 in mitral valve, if you want to replace the mitral valve, and more than 70 for the aortic valve. Bioprosthetic valve also considered if the patient has a risk of hemorrhage, if they are poorly compliant with medicine, and young women of childbearing age. So because we know that there are different valves, which different types of valves, whether we want to do a bioprosthetic valve and whether we want to replace with a metallic valve. Very common questions in valvular heart diseases. So metallic valve we usually consider in others, and elderly who also consider obviously in elderly who are already on anticoagulants. So that one we will consider giving the replacing the valve with the metallic valve. So in the end, I just want to tell you a bit about the murmur. So we're going to listen the recording for the murmur for the mitral regurgitation. So it's a pansystolic murmur, and it will be something like this. So this is the murmur you're going to hear, and it's a pansystolic murmur heard throughout through the systole. And the important thing is, as you can hear, there's no first heart sound or very soft heart sound. First heart sound. So must mention that the patient has a soft first heart sound, and I can hear the pansystolic murmur at the apex, and normally it radiates to axilla. Okay, thank you very much, and see you in my next video.